The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another issue of the Genuine Article. And today what I'd like to discuss is a paper that we've got in press that deals with the important question of exactly how low should the LDL be taken. What is the optimal goal level for LDL reduction in patients with coronary artery disease? Now, if there's one thing that I think virtually all cardiologists take for granted, it's the value of LDL lowering in patients with coronary artery disease. There's just a plethora of studies that have demonstrated that lowering LDL, typically using statins but with other therapy, clearly produces a benefit not only for secondary prevention in patients who already have coronary disease, but even in patients for primary prevention. Now, given those facts, the question arises, what is the optimal degree of LDL lowering that should be undertaken? And this is not an inconsequential question because obviously lowering LDL could potentially have side effects. It is, of course, costly and it creates questions regarding adherence. So with that in mind, there have been a number of studies directed toward that, but a paper we have in press by Dr. Giraldez and colleagues from the TIMI study group went and analyzed the data that was obtained in the Prove It trial to try to look at the effect of baseline LDL levels on how much benefit was achieved with intensive lipid-lowering therapy versus ordinary lipid-lowering therapy. And as you will recall, Prove It compared treatment with 80 milligrams of atorvastatin to that with 40 milligrams of pravastatin in patients who had ACS or acute coronary syndromes. So obviously these Prove It data immediately limit our ability to extrapolate from the ACS group to a conventional stable angina group. Nevertheless, as you recall, intensive lipid-lowering therapy clearly was shown to have a benefit as compared to just ordinary or less intensive lipid-lowering therapy. Now, in this analysis, Giraldez went back and divided all of the patients who were statin naive, so they'd never had statins, and divided them according to their baseline LDL levels before therapy into quartiles. So now you had patients enrolled in the studies, and you could compare those in the highest level of LDL at baseline to those in the lowest quartile for level of LDL at baseline. And they then analyzed the benefit. And what they observed clearly was that, in fact, in the patients with the highest baseline LDL levels, that there was the greatest benefit in intensive lipid lowering as compared to usual lipid lowering. And by the time you got to the lowest quartile of LDL baseline levels, patients whose LDLs were relatively low, in fact, the benefit of intensive lipid lowering as compared to usual lipid lowering was really not able to be discerned in a statistically significant fashion. Now, there were some interesting things to look at in terms of the data. The patients who started with the highest LDLs had the greatest degree of LDL reduction on an absolute basis. That makes sense. But despite that, after therapy, the patients who started with the lowest LDLs still had the lowest LDL levels. So that although there was greater LDL lowering in the high baseline group, it wasn't enough to offset the initial advantage of those who started with a low LDL. So that this is fascinating data. And it would suggest that in patients who have relatively low LDLs to begin with, that intensive lipid lowering may really not be worth the effort. Now, the authors did go back and they conducted a multivariable analysis comparing benefit to continuous levels of LDL. And what they observed was that intensive lowering clearly had a benefit up to an LDL of about 66. So that one may, for the first time, begin thinking that perhaps an LDL of 65 or so may represent an optimal level or an optimal floor for lowering. So as with any study, clearly there were limitations to this one. The two different statins may in fact have different pleiotropic effects. There were, of course, additional variables in the patients who had high or low baseline LDLs. The patients with the low baseline LDLs tended to be older and have more comorbidities, and maybe statins could be less effective in this group. And as we said before, these were ACS patients. So what would I recommend as a take-home message for this? Well, I think for many patients, intensive lipid-lowering therapy does involve an expense. It does subject them to a slightly higher risk of side effects, and it may influence adherence. So that, at least from my own way of thinking, these data support my current policy, which is to shoot to have the LDL in the low 70s in those high-risk patients with coronary artery disease. Clearly, more data will be needed. This will remain an important question, an issue in everyday practice, and hopefully we'll be able to bring that information to you in JACC. For the Genuine article, this is Tony DeMaria.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.